And, one of the things that I think is important to realize about Parkinson's disease is that Parkinson's disease is a systemic disorder. And I'm going to apologize. Give me 1 minute. I want to make sure my fellow is seeing the other patient. So hold on one sec.
Excellent. You and I were talking about that the other day, Brian, how the emotional side, mental side, cognitive side, and hallucinations and delusions side of things can be devastating.
Sorry about that.
Even more than some other things.
All right, sorry about that. So just wanted to make sure everybody was tucked in. What I was saying is, one of the things that I think is important to realize about Parkinson's disease, particularly for patients to have this insight, is that Parkinson's is really a systemic disorder. So what do I mean by that? What I mean by that is that every single organ system in the body is affected by Parkinson's disease. And so if you look at, if you think about all of the different aspects that Parkinson's disease affects, it affects your ability to urinate, constipation, swallowing, sleeping. It can affect mood. It can affect a patient's mood. So there are multiple organ systems that are affected in Parkinson's disease. It's not just a disorder of movement. And so there are really two reasons that happens. So one is it affects a part of the nervous system called the autonomic nervous system. So that's the part of the nervous system that operates in the background. We don't typically think about it. It's it's the part of the nervous system. So for example, if somebody had a sandwich for lunch, that sandwich is being digested and the nutrients are being absorbed, but we're not actively thinking about it. All of that is sort of happening automatically, hence the name autonomic nervous system. But it's really the brain that does that without us really thinking about it. And that part of the nervous system is affected very early in Parkinson's disease. And one of the things that part of the nervous system controls is our blood pressure. So when patients with Parkinson's disease stand up, oftentimes their blood pressure will drop. And the problem with that is it can lead to lots of fatigue, being tired, but it can also lead to falls. And the reason it's particularly important in our discussion is that a lot of the medications and we'll talk about the medicines in a few minutes, but a lot of the medications that we used to use to treat hallucinations and delusions drop blood pressure. And so it's important when we're picking a medication to understand what some of the side effects of that medicine are and how that in particular affects Parkinson's patients, knowing that the autonomic nervous system is affected in Parkinson's disease. The other reason that Parkinson's disease is a systemic disorder is that it affects multiple neurotransmitters in the brain. So neurotransmitters, one way to sort of think about neurotransmitters is that they're little chemicals within the brain that allow one part of the brain to talk to another part of the brain. And so one of those, there are lots of neurotransmitters in the brain. There's acetylcholine, serotonin, glutamate, pretty much any major neurotransmitter system that you can think of is involved in Parkinson's disease. But one in particular, serotonin, is affected very early in Parkinson's disease. And so we're going to talk a little bit about serotonin today and how it plays a role in hallucinations and delusions. We typically think of serotonin as playing a role in mood disorders, so anxiety and depression, but we're going to talk a little bit about how it plays a role in hallucinations and delusions today. So with that, we're going to move forward. So these are the UK Brain Bank criteria for Parkinson's disease. These are the motor criteria that we look for to make a diagnosis of Parkinson's disease. So you need slowness of movement. So that's one of the main symptoms, one of the main motor symptoms of Parkinson's disease. And then some people will have tremors, some will have stiffness. And later on in the disease, you can get balance problems. So those are considered the UK Brain Bank criteria. They're primarily used to make the diagnosis of Parkinson's disease. But there are lots of aspects of Parkinson's disease that have a lot more to do with some of the non-motor symptoms that we talked about earlier. So depression, anxiety, urinary issues, sleep disturbances. But one of the non-motor symptoms can be hallucinations and delusions, and we'll talk a little bit about that. So hallucinations are when you see something that isn't there, or the cousin of a hallucination is an illusion. An illusion is where there's a stimulus there. So for example, there's a pen here, but my brain misinterprets it as a stick. So that would be an example of an illusion. A very common illusion that patients will sometimes describe is seeing a pattern on a tile and thinking, or seeing a little dirt on the floor and thinking that maybe that's a spider or an insect. So that would be an example of an illusion. A hallucination is seeing, seeing a child sitting in a chair when there's nobody there. So those are sort of examples. Delusions, and delusions are important to keep in mind, because delusions sometimes are more problematic than the hallucination. And a delusion is thinking something is happening that isn't actually occurring. So, and one of the most important things to remember about a delusion is that it's not amenable to reason. So if somebody's having a delusion, you cannot reason with them. So I'll give you examples of some very common delusions. There's this delusion that somebody is trying to come into the house, or somebody's trying to hurt a patient, or that the medicine that a patient is receiving is poison. So that's a very common delusion that patients will sometimes have. Another very common delusion might be that the spouse is cheating on them. And so that's another very common delusion. And again, it's important to remember that a delusion is not open to reason. You can't reason with somebody who's having a delusion. There are internal and external. Yeah.
Hey, Doc, before we get into, I know, hallucinations and delusions, they're pretty strong words. And I know that there's black and white definitions in that, but usually when we're dealing with Parkinson's disease, it's really not that black and white. It's finding out why someone may not be eating their full meal, why someone doesn't want to go outside or has some anxiety from doing things. They intertwine with other things, would you say? Am I correct?
They do. They affect lots of things. So I'll give you a few examples. A few years ago, I had a patient who every time he went down the stairs, he would end up falling. And remember, falls are a major issue for Parkinson's patients. It's one of the leading causes of having patients go to the hospital. And so every time he would go down the stairs, he would fall. And the reason was that he was seeing a puddle at the bottom of the stairs that he was trying to avoid. Now, that puddle wasn't actually there, but this is something that he would see. And so he would try and avoid the puddle and he would end up falling. If you sort of think about it, if you think that your wife is cheating on you, that's going to cause a lot of psychological angst. It's going to cause a lot of anxiety. It can affect somebody's ability to be taken care of. So if you think that your caregiver is giving you poison every time they tell you to take your Sinemet and you refuse to take your medicine, your Parkinson's symptoms are going to be a lot worse. So those are just some of the ways how delusions and hallucinations can have a very real impact on patients. Is that what you were asking me about, Brian?
Yeah, because I think when we think of hallucinations, delusions, we don't think that it could be really happening, and it just looks very unreal in that stage. But I think they mask themselves in other areas, whether you gave a good example how one of your patients were cooking a meal for 4, and it made sense that she thought the grandkids were coming over, or the husband thought the grandparents were coming over, and when they were talking about the conversation, he just assumed it was the grandchildren, but it wasn't the grandchildren at all. She saw 2 children that she invited into the house to eat. So those tricky things that how they can mask themselves.
And that also brings up another point, and that is that one of the things we know just like Parkinson's disease is a progressive disorder, right? The motor symptoms over time will get worse and they need to be treated. Hallucinations and delusions are the same way. They will progress over time. And Brian reminded me of a patient of mine who I often talk about, but that in her hallucinations started off as seeing little children. And her grandchildren lived far away, so the little children were almost like a substitute for her grandkids. And it was very pleasurable for her to see these children in their apartment every night. And early on, it wasn't so much of an issue. But as the disease progressed, she started cooking a meal for these kids every night. And now there were just the two of them in the apartment, but she was making a meal for 10 people. And so that's the part where you have to remember that it may start off as a very sort of innocuous or something that doesn't really bother the patient very much, doesn't really bother the caregiver very much, but over time it will progress. And one of the other things to remember is that this is not something you want to wait to treat until it's an emergency, because when it's an emergency, patients in the hospital, they're delusional or hallucinating, fighting with the staff, in restraints. That's not the time to treat this. The time to treat this is before that happens, when patients have a say in what happens to them and how they're treated. So, it's important to remember that we have good treatments for this, and the earlier we treat this, the more successful the treatment will be. And the less, the fewer medications that will be needed to treat it. So typically, the longer somebody waits to treat this, those are the patients that require 2 or 3 different medications to control the psychosis. So the earlier we treat it, the better somebody is going to do. So let me very quickly talk about internal and external causes. So internal causes are things we don't have a lot of control over. What stage of the disease? Is there a prior history of mental health disorders, vision problems? External causes are things that we do have some control over, medications, alcohol, drug use, the light level. So simply raising the light level can make a big difference. And that's one of the things that we do before we try medications is some of the conservative therapies. So talking to your loved one, reorientation, what time of day it is, where they are, who you are. And then in the evening times, raising the level of the light in the home can be very helpful in controlling some of these hallucinations and delusions. But over time, again, remember what I said, over time it will progress, and most patients will require medication to treat this. And so one of the other things that I think is important, remember, hallucinations and delusions will get worse over time, but it's a slow process. Just like Parkinson's disease slowly progresses, typically over years, not months or weeks. So if there's a sudden change, if suddenly somebody who doesn't have any hallucinations and delusions develops them, or there's a sudden increase in the severity of the hallucinations and delusions. So typically in that scenario, there's something outside of the brain affecting the brain, and that something is typically an infection or an electrolyte abnormality. And so you always want to make sure that you tell your doctor if there's a sudden change, because what they may do is just order some blood work. So checking the blood for any electrolyte abnormalities, dehydration, infection, and then checking the urine to make sure there's no infection there. So, and that's called a metabolic encephalopathy. Again, the name doesn't matter so much. The concept does, and the main point here is if there is a sudden change, you always want to let your physician know, and typically they'll order some blood work and some urine testing. So we've sort of talked about, so this is an illusion. The problem here is that the sock looks like a mouse. Hallucinations can come in many different forms. The most common one is visual, seeing things, but you can have auditory hallucinations. Some patients will hear music. You can have tactile hallucinations, so touch. So I've had patients tell me that they feel like somebody is touching them. I recently saw a patient who felt that their husband who had passed away many years ago was touching them on the back. So you can have tactile hallucinations. They can come in many forms, but again, visual hallucinations are the most common. What's the problem here? Obviously, the problem is that there are no children there, but he's seeing a reflection of the children in the water. And again, sometimes this is how hallucinations start. And eventually the children won't just be a reflection, they'll actually be standing there next to him. Delusions, we've talked about a little bit already. Again, jealousy delusions are very common, particularly in men. Persecutory delusions, somebody's trying to get me. The medicine that they're giving me is poison. I don't want to take it. Very common delusions that we see in our patients. What's the problem there? He thinks somebody is trying to come into the house, right? So that's a delusion where he thinks somebody's trying to come get him. We've talked about progression already. We're going to keep moving. So this is important. There's a myth out there that hallucinations and delusions always basically go together with dementia. So somebody has to have memory problems and cognitive issues, and then you see the hallucinations and delusions. And that's not the case. There are lots of patients where they may have hallucinations and delusions, but not have any cognitive issues. So that's important to remember. The other point here is that it's important to separate dreams from when somebody is awake. There's a very common symptom in Parkinson's disease called REM behavior disorder, so acting out of dreams. And that is, it's very common. It's one of the earliest symptoms of Parkinson's disease, but that is not a hallucination. Hallucinations happen when somebody is completely awake and they're seeing something. Acting out of a dream or having a very vivid or lifelike dream, that's not a hallucination. It's important to make the distinction because the treatments are very different between the two of them. REM behavior disorder, acting out of dreams, typically is treated with clonazepam. Hallucinations are typically treated with antipsychotics. So let's see here. One of the statistics that you'll oftentimes see is that about 50% of Parkinson's patients at some point during the course of their illness will have to deal with this. It's important to remember that this is also one of the leading causes of why patients end up having to leave their home. And the other piece of that is that most patients are reluctant to bring this up to their doctor. And then the flip side is most doctors are reluctant to bring it up with their patients. And so you have an illness that 50% of PD patients will have to deal with, a symptom that 50% of Parkinson's patients will have to deal with. It's one of the leading causes of patients having to leave their home, and nobody wants to talk about it. So it really is incumbent on patients and their caregivers to bring this up if it's happening. And the reason you want to bring it up is that since 2016, we actually have good treatments for this, right? So we've talked about this already. We're going to keep moving forward. So this, I really like this slide, and the main point here is that this is a team approach. The caregiver and the patient and then the healthcare provider are all important parts of this team. And a lot of times the caregiver can provide insight that the patient may not be able to provide. So it's important to keep that in mind. The other things that I would add to this would be physical therapists. Exercise is incredibly important for Parkinson's patients, not just for the physical well-being, but also for the mental well-being. So let's talk about the treatments for Parkinson's disease. So prior to 2016, we didn't have very good treatments for Parkinson's disease, and for Parkinson's disease psychosis. And in fact, all of the treatments that we had for PD psychosis were medications that had been studied and used in schizophrenia patients. So what's the biggest difference between schizophrenia patients and Parkinson's patients? And the obvious answer there to me is their age. Right? So prior to 2016, all of the antipsychotics that we used to treat Parkinson's disease psychosis were studied in schizophrenia patients. And so we were using medications that were designed for patients in their 30s, 40s, and 50s to treat patients in their 60s, 70s, and 80s. And there's an inherent problem there because somebody in their 50s is not the same person as somebody in their 70s or 80s. And Nuplazid or pimavanserin is the first and the only medication that's specifically designed to treat Parkinson's. It's specifically designed to treat hallucinations and delusions in Parkinson's disease patients. The average age of the patient in these studies was 72 years old. So much more reflective of the patients that we actually treat than some of the other medications that we used to use. So Nuplazid or pimavanserin does come with a black box warning. Every antipsychotic currently available in the United States comes with a black box warning, but Nuplazid has a little bit of a modification. So I'll read you the first bullet point, which is true of every antipsychotic currently available. So medicines like Nuplazid can raise the risk of death in elderly people who have lost touch with reality, psychosis due to confusion and memory loss or dementia. So essentially, the risk of death in somebody with dementia increases if you treat them with an atypical antipsychotic or a typical antipsychotic. Here's the modification for Nuplazid. So the FDA sort of realized that Nuplazid works in a little bit different way than all of the other antipsychotics. And so the modification is that Nuplazid is not approved for the treatment of patients with dementia-related psychosis unrelated to the hallucinations and delusions associated with Parkinson's disease psychosis. So essentially what the FDA is saying is that if somebody has Parkinson's disease and they have psychosis, regardless of whether they have dementia or not, it is okay to use this medication in that group of patients, okay? How does Nuplazid work? So I think it's important for patients to know how their medications work. And so all of the other antipsychotics that came before pimavanserin worked on dopamine. The way they controlled psychosis was by blocking dopamine. The problem in a Parkinson's patient is that if you block dopamine in a Parkinson's patient, somebody who's not making enough dopamine to begin with, the risk is that you're going to significantly increase their motor symptoms, the walking, the stiffness, the tremor, the balance problems, right? So if you block the dopamine, what little dopamine that there is available, their symptoms are going to get dramatically worse. Nuplazid is really the first antipsychotic that doesn't work on the dopamine system. It doesn't touch the dopaminergic system at all, and it primarily works on the serotonergic system. So it blocks one particular serotonin receptor, and that's the way it controls psychosis. And so what that means is it doesn't affect the motor symptoms of Parkinson's disease. It doesn't make them worse because it doesn't affect the dopamine receptor. Okay. So in the clinical study, so there was the pivotal study or the main study that was done that led to the approval of Nuplazid. It was what they were able to show in that study was that there was a statistically significant reduction in the occurrence of hallucinations and delusions in patients with Parkinson's disease. And again, the average age of the patients in that study was 72 years old. And so what they did was they took a group of patients, and the patients didn't know who was getting the active drug, and the physicians who were prescribing the medication didn't know who was getting the active drug. And half the patients were randomly assigned to get placebo or sugar pills, and the other half was assigned to get Nuplazid. And then at the end of the study, they looked and determined who got the active drug, who got placebo, and who had an improvement in their hallucinations and delusions. And what they were able to show very clearly is that the Nuplazid group had a statistically significant improvement over the sugar pills or placebo. The average, so it took one of the things to remember about pimavanserin is that it doesn't work right away. It takes about 6 to 8 weeks to work. So when you get this medicine, it's important to realize that you have to be patient. Give it some time to work. I typically tell patients about 2 months. And not every patient will respond to Nuplazid, but in the studies, if I'm remembering this correctly, about 65% of patients had a meaningful, clinically meaningful reduction in their hallucinations and delusions. Okay. Again, I mentioned this earlier, but the key point here is there was no worsening in their motor symptoms. And again, the reason is it didn't bind to dopamine like all of the other atypical antipsychotics that came before it. You don't need, it doesn't interact with any of the medications that are typically used to treat Parkinson's disease, including carbidopa, levodopa, so you don't need to adjust any dosages of the other medications. Here's the side effect profile. The main things that I always tell my patients is that in about seven out of 100 people, you can see some swelling. If you stop the drug, it'll go away. So if that happens, it's important to bring it up to your physician. And then feeling confused or having an increase in the hallucinations, that can also sometimes happen. So if that happens, you do want to bring that up with your physician. And the main point to remember there is that this won't be just a subtle change. This will be an obvious change. If you have something called QTC prolongation, or you know that you're on a medication that also prolongs QTC interval, please let your doctor know. QTC is a measure of within the EKG of your heart rhythm. So if that's an issue, let your physician know. One other thing, it is pimavanserin is hepatically cleared, so it's cleared by the liver. So if you have any liver issues, please let your physician know that. And as is true of any medication, you always want to tell your doctor all of the medications that you're taking. It is easy to take. It's once a day, one 34 milligram tablet once a day. And that's pretty much it. In terms of cost, I'll let Brian say a few words about this, but the main thing I want to mention is that from what I understand, the cost to somebody on Medicare shouldn't be more than $20 to $30 a month. Correct, Brian?
Yeah, that's correct. The average cost is less than $20 a month for patients. And that could be there could be help out there with foundations.
Yeah. So I'm going to stop there in the interest of time, and I'll open it up to any questions if there are any.
Thank you, doctor. That's really great information. And yeah, please, people who are watching, if you have any questions, please type them in the comments or the chat box here on Zoom.
Hey, Doc, I got a quick question, two quick questions. So you talk about these hallucinations. How long do you think it typically takes a patient or a caregiver to bring them up to their physicians? Is it something that you ask, or what advice would you give to like caregivers or patients to doing so?
Yes. So, in my practice, I always ask about this. This is something I screen for at every visit because I know it's very, very common. But what I also know is that a lot of physicians won't bring this up. And from a caregiver perspective and from a patient perspective, most patients and most caregivers don't bring this up. And there's this reluctance to talk about it. We sort of tend not to talk about the elephant in the room. And so the advice I would give to caregivers and patients is that if this is happening, don't wait until it's a major problem. Bring it up early, because remember that the time to treat this is early, before it's become a problem. Because if you wait until it's a problem, it's much, much harder to treat. And that's when patients end up going to the emergency room. And what happens in the emergency room is that a lot of times these patients will be given a medication called Haldol or Risperdal, which does block dopamine. And all of a sudden, their Parkinson's symptoms get dramatically worse. So again, much better to treat this early before it becomes a major problem.
I love that you're just speaking like this, doctor, because I work, as rehabilitation here with many, many people with Parkinson's. And one of the things we find is that, and with all due respect to the neurology community, these questions are not asked. This topic is not brought up a lot of the times. And I think it can be really one of the more debilitating things. This can maybe negatively affect movement, maybe more than their actual lack of balance. And it can, hallucinations, delusions. So I have a gentleman right now I see who sees the troops outside of his window. They're going to come and attack him. And there are no troops, of course. But this is great information. I do have one question from a friend of mine, Laura. Laura says, thank you for the information. It's very interesting. Is it more common? Is this, like delusions and things, more common when a patient presents with depression or not necessarily?
Yes, it is. So any prior history of depression or anxiety or any mental health disorder increases your risk of having this. So it is more common in patients who have a prior history of depression or anxiety. And what you were saying, that you know, this oftentimes is far more problematic for patients and their quality of life than the tremor or the stiffness or any of the motor symptoms. You're exactly right in that. And you're absolutely right. We don't ask about it. And yet it's one of the most debilitating symptoms. And it's the leading cause of patients leaving their home and going to a facility.
Is there any relation, also from Laura, any relation with vivid dreams? Like if someone has more vivid dreams, are they more likely to have delusions, let's say?
Oftentimes, vivid dreams are the precursor to having hallucinations and delusions. So yes, there does seem to be a correlation.
Okay, thank you. Thank you. Any other questions from anybody out there?
Yeah, Doc, how would you say that this first starts? Is it different with people, or does it tend to say, like, I know that false sense of presence comes up a lot. Can you define what that is and how one may experience that?
Yeah, so false sense of presence is this sense that somebody is sitting or standing next to you. And usually patients realize that there's nobody there, right? But the way and that certainly does happen. You know, we do see patients with that. What I typically see in my patients is that this will start off very innocently. The lampshade changes colors, or the lampshade the design or the pattern on the lampshade changes, and that's all it is initially. And maybe that doesn't necessarily need to be treated, but you want to follow that person very closely, because what I know for a fact is that it will get worse over time and it's going to need to be treated. And so, you know, the other thing that I see very commonly is they're looking at a carpet and there's a pattern on the carpet and it'll start to shimmer or move, or they'll see an insect where there isn't one. Hold on one sec.
She did. Super interesting.
I'll be right there.
Okay.
Give me 2 minutes. Okay. Thanks, Dan. So sometimes they may see that, but that's typically how it starts, sort of very innocuously, and then it'll slowly progress from there. Okay.
Okay. My next question would be, can a patient have Parkinson's and dementia, and would that be a good, would Nuplazid be appropriate?
Yes. So there are lots of patients with Parkinson's disease that do happen to have dementia as well, and also have hallucinations and delusions. And you can certainly use Nuplazid in that group of patients. One of the things to remember about Parkinson's disease psychosis is dementia is not a prerequisite. You don't need to have dementia to have hallucinations and delusions. But if you happen to have dementia and hallucinations and delusions, it's perfectly okay to still use Nuplazid. Okay.
Just one more question. Do you have time for one more question?
Yep, go ahead.
Okay, thank you so much. Actually, it's 3 questions, but in kind of one. What percentage of your patients are prescribed Nuplazid? Besides the medication, what else should a person with PD be doing? And like what kind of therapy? That's it.
So I can't give you an exact percentage of my patients that are prescribed Nuplazid. What I can tell you is I probably write at least 2 to 3 prescriptions every week And so it is my first line therapy for PD psychosis. It's the medication that I use the most and use first when I see somebody with hallucinations and delusions. And I've been using it since 2016, and I've had a good experience with it. I've had good tolerability, few side effects, and good benefit. In terms of what sorts of therapy, so what I tell patients is that you want to take care of your mind and you want to take care of your body, and the two are interrelated. Your physical therapy is going to help with your mind and it's going to help with your body. And your cognitive, doing something that keeps you cognitively engaged and stimulated, is going to help with your mind and it's going to help with your body. So both sides of the equation matter.
Perfect. Thank you.
Okay.
Thank you so much. Any other questions? I just want to, Laura says, thank you. Excellent presentation. Doctor, thanks so much for joining us. It's really a pleasure to have you.
Thank you for having me. It was a pleasure. And Brian, thank you for putting this together.
Thank you, Doc. Have a great day.
Take care. Bye-bye.
Take care. Bye. So, Brian, we can move on here. I have a few slides to share when you're ready. No hurry. But anything you want to talk about prior to me doing this?
No, just a review of Dr. Amjad's presentation. Hallucinations and delusions are something that we need to express more and talk about, whether it's with your physical therapy, your primary care doctor, your movement specialist, or any neurologist that you see. It's important that it's treated. I will add that this time of year, it may happen more often because of the serotonin and how the sunlight affects that. So as the sun goes down earlier, we may see more of these hallucinations and delusions throughout our loved ones. So it's just important that we talk about it, that we document it, and that the doctor is aware of it. I think what Dr. Amjad said, that is treating it earlier is probably one of the best ways to deal with it. We know that exercise helps, and we know that sunlight helps. So, living up here in the Northeast, we know that it's going to get darker and darker as earlier and earlier. So, let's get out there and try to be active, and let's try to eat healthy, and let's just have a better relationship with our caregivers.
Absolutely. I couldn't agree more. Well, if you're ready, I'll move forward with a very quick presentation.
Yeah.
Okay, so before we do this, I just want to just say first that what Dr. Amjad was saying is how the mind, cognitive and body and mind is interconnected. So we need to be exercising everything we can, our body and our brain.